I'm Jim McCaffery, and I'm with CapacityPlus as a Senior Technical Advisor. And what we're going to do today in the hour and a half that we have is I'm going to begin with a few opening remarks about making sure that we're clear about what multidisciplinary teams are in the context we're looking at, and provide a couple of sort of principles around them and benefits. And then we're going to have two really good examples of multidisciplinary teams in action. One from Lynette Mudekunye from REPSSI, and one from Bernadette Madrid from the Philippines. Between these two, after each one, we'll have a chance to have some discussion and questions that come up in the chat box. Lynette and others can respond to. Then we will have Bernadette's presentation, and we'll do the same thing. And then we will take a step back and look at all the comments and all the questions that have come up, and then any final overall general questions. And then I'll say a few opening remarks, and we'll take a look at the future. So that's what we'll be doing today. So let's go ahead and start. I should say one other thing about the chat box. It's very useful for asking questions. Many times the questions are then addressed by other people from other countries or other programs in the chat box. So it's not always directed at the speakers. So we'll see how that works today. Okay, so in terms of multidisciplinary teams for today, we're using a very simple definition for this, and that is different disciplines, people from different disciplines working together to deliver a full spectrum of services to vulnerable children and families. So that's the definition. There are other ways that this could be defined, but in our setting, this is what it is. It's bringing these disciplines together to provide that spectrum. And one of the questions that comes up is why do this? And what we have seen is at least these six different reasons for doing it. One is that it provides a holistic and more systemic approach to situations and problems. And I'm going to take an example not from today's subject, because we'll have two really good examples. So I was going to look at the issue of community water supplies and as a contributor to public health at the community level. And there's a good deal of history in countries trying to improve community water supplies. And when the effort to do that started, it was largely seen as a kind of engineering problem. What can we do at the community level to find appropriate water supplies, to dig boreholes, to provide the engineering to make the boreholes work, and so on? And what they discovered is that after doing this, times the water supplies didn't last very long. And what was the problem with it was that they didn't recognize that you needed some knowledge about the community and how it used water and what the community health problems were, and what simple financing arrangements could be made to make certain that there was some basic maintenance and so on. So what happened is they began to look at teams that had, might include an engineer, but also might include a community health worker or a health worker at the community level who knew both the community well and the health situation, a community leader, an institutional development specialist, and a financial analyst, and that these teams then could work together to see the problem in a more holistic way. And hold on a second. And to take a more systemic approach to it, and to look at the situation and come up with problems. having these disciplines together made them more effective and made the decisions better informed as the different perspectives came together to look at a particular community water supply problem. So you had a finance perspective, an engineering perspective, a community perspective around what might work and what might not work. And so you'd get these better informed decisions, and they would be more effective. The third thing that was likely to result in more sustainable solutions because of the comprehensiveness of the analysis of it, and also because there was inclusion of the different actors that had to implement the solution. There was less duplication because if you did them, you could have these services or these functions being performed independently, but there would be then duplication, as an engineer might look at something and then a financial analyst might come in later and look at something, and there would be a certain level of duplication. I think what they found also is more innovative approaches developed from this, because as people listened to each other across disciplines, they often came up with solutions that they wouldn't have come up with by themselves, and their discussions often produced a kind of synergy. And I think the other one is that it can lead to also professional satisfaction, because you feel you're doing your work better as a result of taking this approach, and you're also part of a larger community that's trying to solve issues. So I just wanted to mention these as sort of why do this, because it does take a little bit more time, a little bit more effort. Sometimes it takes more training to do this and work together, more planning, and so there are some costs involved in it, but there's some real important benefits. So that was what I wanted to start with opening kind of remark and taking from the community water supply situation and how it contributes to health. And now we'll go ahead and move on to our first presentation. And again, just a reminder, feel free to write questions or comments as we go in the chat window if a question occurs to you, and we'll do our best to address these questions following the presentations. So the first presentation will be from Lynette on multidisciplinary teams and lessons learned from the community-based work with children and youth certificate program. Now, Lynette is an advisor on program issues in REPSSI, which is the Regional Psychosocial Initiative, and it's a regional organization working in 13 countries in East and Southern Africa to promote psychosocial well-being of vulnerable children and youth within their families and communities. REPSSI has pioneered the provision of accredited training in psychosocial care, support, and protection, including a certificate for community workers and a diploma for teachers, both of which are offered to groups of students through supported distance learning. So that's a little bit about Lynette, and with that, I'm going to turn the microphone over to Lynette, and we'll look forward to her presentation.
Good afternoon, everybody. It's my pleasure to join you this afternoon to tell you a little bit about how we are learning about multidisciplinary teams through this certificate program. Just to set the scene, the social service workforce is a variety of workers, paid, unpaid, government, and non-governmental, who are staffing the social service system. That means they're people who are contributing to the care of vulnerable populations. REPSSI began this community-based work with children and youth certificate, which is a 6-module course, quality assured by the University of KwaZulu-Natal, and the 6 modules are quickly personal and professional development, human rights and child protection, child and youth development, care and support of children at risk, integrated development in communities, and a service learning project. Thinking that our target group was mainly community caregivers, or those that we often discuss as volunteers, We were actually quite surprised to find that there was great demand from many others, and these for us are the social service workforce. So some of the people who've been on the course and who have found great value in it are teachers, social workers, community child caregivers, VCT counselors and community nurses, ECD practitioners, home-based care workers, police, and people working in the judiciary. The certificate is given through what we call situated supported distance learning. Situated means that a group of between 10 and 20 students meet together in wherever they are, where they're working. They meet one day in 3 weeks with a mentor who facilitates a discussion between them. Otherwise, they study from hardcover book modules, and they write assignments which are then sent to an academic institute for marking. Because we began having this wide range of disciplines who came together, we found that it was an opportunity for sharing and coordination, and we were quite conscious in promoting this in some of the countries where the certificate has been offered. The certificate has now been offered in 3 different iterations. That was the countries for the first one, those were the second, and this is the third group. So what has happened in terms of promoting multidisciplinary collaboration between groups of different people? I'm going to give us a few examples. The first one is Solwezi in Zambia, which is a corner of Zambia almost to DRC, almost to Angola, up there. And in that group, we had a member from the Police Victim Empowerment Unit, from an organization dealing with people with disabilities, drug enforcement, NGO and FBOs, social welfare officer, prison staff who are working with children and youth who are in prison. So that was the composition of the group. Community development and gender focal people. What we found in this particular group is that many of these different disciplines already belonged to a coordinating group, which might be an AIDS task force, a child protection committee. However, by studying together and meeting this one day every 3 weeks, the level of collaboration between them really improved and increased. And the main collaboration has been increased referrals between group members. Even though they graduated more than a year ago, they are still working together. One example is that one of the team members identified a young man with a disability who was begging in town, and when she stopped to talk to him, found out that he was supporting 2 younger siblings. She then spoke to another member of the group who was in the Catholic sponsorship program, and they were able to arrange scholarships for the 2 younger siblings to go to school. She spoke to a social welfare officer who was able to organize other support, and finally brought in the participant from the Association of People with Disabilities, who was able to make available support for the young boy who was only 15, and he no longer has to beg to support the family. Another group is Mutare group in Zimbabwe. That group includes health workers, police, teachers, NGO and CBO workers, as well as community caregivers. And again, there are more referrals between group members. One example is a teacher who has now identified a child who is being abused. And one thing we have found is teachers who might before just not have noticed or turned a blind eye are now paying attention and identifying cases of abuse. She referred the child to a colleague on the course who is with the Family Support Trust for examination and counseling. I then realized that the parents of this young girl were very resistant to investigation of the case, so they referred it to a policeman who's also in their group, who's within the victim-friendly unit. And as we speak, investigations are continuing. That case is being followed up. A third example is the GWERU group, also in Zimbabwe. That group included an intermediary or a translator from the magistrate's court, police officer, health personnel, and NGO officers. The intermediary from the magistrate's court firstly encouraged the whole magistrate's court to use the victim-friendly courts for all cases involving children, including children who were in conflict with the law. They then also have made much more effective use of the multidisciplinary committee that they had already for the victim-friendly system. So they have a victim-friendly subcommittee of the Child Protection Committee. And some examples of how they have done this are a case of attempted rape of a young girl, which previously might never have even been followed up. It has been followed up. They moved the child to a children's home as a temporary measure, as they are trying to locate relatives who live close enough to a school for her to be able to go to school and not just be moved to relatives and be out of school. Another example is a young boy who had been sodomized. The case came to court. They realized that he was being sodomized by an older cousin that he was living with, and rather than just ending the case there, they went deeper into it and realized that the older boy had also been sodomized by a neighbor. They've been able to move the younger one to now live with a grandmother, and they're following up and know that he's in school. So these cases are getting follow-up beyond the court case. The final example here is a 10-year-old girl who came to court because she'd been raped by an uncle. In talking to her and trying to get the story from her, they realized that she could not really read and write at a level that would be expected of a 10-year-old, and that she wasn't in school. She'd been moving between different relatives and hadn't been able to be in school. So they've been able to place her with a maternal aunt. The Ministry of Education and Social Services are working together, and they've been able to get her assistance from the Zimbabwean Basic Education Program, which provides assistance to vulnerable children for school fees. We have found that technology is being used and can be used much more effectively to foster teamwork. There has been rapid expansion of technology in Africa, both cell phones and internet. So in Swaziland, some of the mentor groups have set up WhatsApp groups on their cell phones so they can quickly share any issue that comes up between the whole group and quickly come up with ideas and suggestions. In Zimbabwe, all of the mentors, there are 9 mentors in different provinces, belong to an email group. And they talk to one another over email fairly regularly. It's been particularly useful for the newer mentors to get support from some of the older ones. This has really made us think, what is it that we can do to foster this multidisciplinary team development? We realize it's a byproduct, if you like, of the certificate program, but we could build it into the program much more intentionally. One of the factors that helps is that where students already belong to a multidisciplinary coordinating committee, the program helps them to use that more effectively. So we could encourage all of our certificate students to join one of these committees. Another factor definitely is the mentor. We know that the mentors are really essential in fostering collaboration between their students. Many of them have encouraged their students to meet in smaller buddy groups, and that's helping. They also can encourage their students to bring real case stories to their group discussions. The last area that we think we could strengthen is course material. It does already encourage networking and sharing, but we're sure we could review it to make it stronger. And the mentor outlines of how to run their sessions could use specific activities to encourage collaboration. We're going to investigate these further, and we're very happy to have been part of this discussion because it's made us really think about it in detail. Just to mention that in the teacher's diploma, we were much more intentional in promoting the idea of a network of support, and we've encouraged all of the teachers right at the beginning of the course to set up a directory of support that they will use to be able to link up and refer children that they find in their schools to other services in their community. This course is still in its first cycle in Zambia, so we will be looking to see whether our encouragement has really resulted in this process happening. Thank you. I would really like to thank the mentors and students in Swaziland, Zambia, and Zimbabwe who shared their experiences for this presentation, and my colleagues, including Lisa, who is typing away there madly. Thank you so much.
Thank you so much, Lynette, for a great presentation. This is Amy Bess. I'm the coordinator for the Global Social Service Workforce Alliance, and I'll be moderating today's question and answer period. So I do encourage you, if you have any questions, to type them into the chat window, and we will address those questions. I will address those questions to Lynette. Lynette, you've given a great presentation highlighting such a broad range of disciplines that are working together, whether it's teachers or people from the magistrate's office, police, child protection committee members. And it's great to hear about how they're taking the courses together and that this then strengthens some of the existing coordination mechanisms that already exist. And then also, as you talked about after the course, some of the technology to connect the mentors, for example, some of the buddy groups. I am interested especially in some of the technology that you mentioned, and maybe we can just start with a straightforward question about if you can tell us a little bit more about the What's Up groups and how those work. And then we'll address some of these participant questions that are coming in. So over to you, Lynette.
WhatsApp group is really everybody signs up on WhatsApp on their telephone and you form a group. And then when you have an issue, be it an issue with your work or an issue with your studies, a section you haven't understood, an assignment you're struggling with, you can write to the whole group and all the members can come back to you very quickly and give you support and answers, help you out. And as Lisa said,
Great, thank you.
It's a cell phone application, so it's cell phone coverage moving throughout.
Great, thank you, Lynette. Some of the chat in the window is also about the future of REPSSI, and especially in terms of expansion and particularly to West Africa, and if REPSSI has considered that, or if you could just talk a little bit more about the future plans for REPSSI.
The joy of both the certificate program and the teacher's diploma is that they are offered through distance learning in collaboration with a local academic institution. So they are fairly flexible. We could take them to other countries. We currently don't have plans to do that, but those are fairly easy to move to other countries. So if there are people who would have specific ideas on how we could do it, we'd be happy to talk to you.
Fantastic, thank you. And I already see a few connections being made in the chat window between Zimbabwe and Nigeria, and Ohenga and Lisa are connecting, so that is great. And Jim McCaffery has a question about the victim-friendly units. Did they participate in the courses with everyone, and what about the translator intermediaries?
Yes, the police from the victim-friendly units have participated in the course in a number of countries. One of our star police women, who is the one in the picture there, is in Swaziland, and when she completed the course, she was actually promoted to become a trainer in the training college for police because they wanted her to be able to share what she now knew. So and the translator from the intermediary was in the course, completed it, and has used what he's learned from it in now being able to talk to children, to dig deeper, not just translate what they tell him, but find out a bit more around the circumstances of their lives and what had happened to them, and even where their perpetrators had problems. And nurses and social workers, we've had a lot of different people all participating in the program and gaining their certificate.
Thank you. And Naomi Hill asked a question about whether you've tracked the career developments of learners once they have completed your courses, and what do they move on to? And Lisa is providing some great answers there, saying that 24% of the students who were volunteers at the beginning were in paid employment following the course, and that 74% of them attributed this to being on the course. Lynette, if you have anything to add to that, feel free to make any comments. Thanks.
We don't have detailed data on where they have moved to. We do know some, like I told you, the policewoman in Swaziland who's now in the training college. I was in Swaziland a few weeks ago, and a young man said, "You're the people from the course with the UKZN. I've now got a job with a program with young offenders, rehabilitation of young offenders, and I owe my job to that certificate program." So we do need to have a more regular follow-up to know where they've gone. What we do know is the 24% moved into paid employment, but not specifically where that paid employment is. Many of the others have stayed where they were. The court interpreter is still a court interpreter. But doing more with his knowledge where he was before.
All right, and we have one question from Thaya about the support that REPSSI provides following the training, and what form could or does this support take? If you could comment a little bit more on that, what happens after the courses.
What we are building now is a much stronger network with the organizations that these people came from, because everybody was from somewhere, whether it was a CBO or an NGO or an FBO or the police, so that we have that support mechanism built into it. But that was not built in originally into the program. It was an academic course.
All right, thanks. And Lucy Steinitz in Ethiopia asked a question about the different levels of the learners on the courses. And she asks, what difference have you identified between people who have already had some post-secondary education, perhaps such as nurses or police, and those that are far less educated who have historically been our volunteer cadre with a grade 10 education or less?
The certificate program has been offered to people aged between 19 and 70. A number of the older ones had what was traditionally the end of primary school, standard 6 around here. And in many cases, the people with the lower levels of education have actually done better in terms of their marks than those with higher education. We've had people who even have master's degrees taking the course as well because they wanted the specialization in children. But it's really focused on hands-on understanding of working with children.
All right, thank you so much, Lynette. We do have a period of time after both presentations for a general group discussion. So there are still a lot of great questions coming in. Everyone keep thinking of those questions. We're going to move on now to a presentation by Bernadette Madrid, but we will have time at the end for some more discussion. So I will hand over to Jim McCaffery, who will introduce our next speaker. Thanks so much again, Lynette.
Okay, thank you, Lynette, and thanks, Lisa, and thanks to everybody for writing in and asking questions and carrying on a bit of a conversation. And obviously, this will still continue on as we move ahead to the next example, which is hospital-based child protection multidisciplinary teams in the Philippines. And Bernadette Madrid is going to be the presenter for this. Bernadette is the executive director of the Child Protection Network Foundation, which is an NGO that supports the training of child protection professionals and the development of child protection units in the Philippines. She is also the head of the Child Protection Unit of the University of the Philippines, Manila, the Philippine General Hospital, where she is concurrently Associate Clinical Professor of Pediatrics and acting head of the ambulatory section. She also serves as the professional lecturer too at the Philippines Judicial Academy and served on the Executive Council of International Society for the Prevention of Child Abuse and Neglect from 2004 through 2010. So that is a little bit about Bernadette. And Bernadette, I'll now turn the microphone over to you, and you can take it from here. Thank you.
Thank you, Jim. I hope you can all hear me. Good morning or good afternoon or good evening, depending on your time zone. Greetings from Manila. What I would like to do for the next several minutes is to discuss the establishment of child protection multidisciplinary teams in the Philippines, known as Child Protection Units or CPUs for short. I will focus on the conditions necessary to set up a CPU, the members of the multidisciplinary teams, their training needs, and the institutional support for different child protection unit levels. I will then give an example of a CPU that is level 3 or a training center, and I will discuss what these different levels are. But before we start, I would like us to be clear what I mean by a child protection unit or a CPU. It is a child-friendly unit using a multidisciplinary approach and networking in providing comprehensive medical, psychological, social, and legal services to abused children and their families. Now, in the Philippines, most of the time, we combine a child protection and a woman protection unit to become a woman and child protection unit, because as we know, women and child abuse are closely intertwined. These are usually hospital-based, and right now there are 55 WCPUs spread across the Philippine archipelago. The goal of the Child Protection Network Foundation is to at least have one WCPU in each province. We still have a long way to go, since only 35 out of 81 provinces have a WCPU. Now, depending on resources, the composition of the team can range from a basic physician and social worker working together in one unit, and that's a level 1 CPU, and this can go on to have a police officer or a mental health professional, depending, again, I said, on availability as a member of the multidisciplinary team. In this next slide, you will see that we have a ladderized system from level 1, 2, and 3. So you could see here that a level 1 CPU, in terms of personnel, will have a trained physician, a trained registered social worker, and nurse working together in one unit, providing acute medical care for abused children, a medical legal exam or a forensic exam, social work intervention in the form of safety and risk assessment and case management, peer review, and also providing expert testimony in court. While most of the time it's the physician who provides expert testimony in court, more and more now we also see social workers being called to give testimony in court. You could also see that as we go to level 2, aside from the physician and social worker, we now have either a police officer or a mental health professional as a member of the team, and relatedly, you see also additional services because of that. Level 3 is now a training center, and you have more personnel. You now have there the doctor, the social worker, the police, the mental health professional, as well as some other subspecialty consultations and support services. So level 3 is the highest level. The legal mandate for this, we have a law in the Philippines known as the Rape Victim Assistance and Protection Act, but this law is rather old. It was in 1998 it was enacted, and it was basically not implemented, and it had no funding. But recently, just last March 2013, the Department of Health came out with a new administrative order in the establishment of these women and child protection units. Some of the things that I will be discussing in the next slides will be covering some of the things here that's stated in the administrative order, including the different levels of CPUs. In our experience, however, to ensure institutional support, especially from hospitals that are under the local government, a local legislation may be necessary. And this local legislation usually deals with the support of the local government, such as with regards personnel and budget. There are many parties involved in the setting up of this child protection unit, such as the local government, the police, the Child Protection Network Foundation. So to be sure that all parties are clear on their roles and responsibilities, a memorandum of agreement is signed so that it's clear, what each one needs to do. Now, support by the local government is usually shown by having a dedicated physician and social worker working together in one physical space. If this is a level 1 CPU, and they will pass the local legislation for budgetary support of this CPU. The local government should also agree that the physician and the social worker will undergo training. The provincial police commander is both under the local government and the Philippine National Police, and they also sign in this memorandum of agreement that they agree to designate one police officer in the Women and Child Protection Desk in the police station to be a member of the team and to also undergo training. Now, what is this training about? We have what we call the Women and Child Protection Specialist Training, and this is a certificate training. It takes 6 weeks for physicians, 4 weeks for social workers, and 4 weeks for the police. And this is done in 2-week segments on site. And the members of the team have to train together. It also helps in the bonding. And the training has a theoretical component and a practice component with a required number of cases to see while training. Depending on the team's chosen schedule, they can complete the training within 3 months or to a maximum of 1 year. They have to pass a written and practical exam at the end of the training. Now, there are 2 versions of this training. One is completely on-site at the Philippine General Hospital, which is part of the University of the Philippines, Manila. Actually, their certificate is signed by both the Chancellor of the university as well as the Dean of the College of Medicine, the Secretary of the Department of Health, and the Chief of Police of the whole country. So it's a valued certificate. The second way of delivering this training is what we call the blended learning, which is a combination of online and on-site. There's 11 modules for physicians and 10 modules for social workers. This is usually done for resource-poor areas where the physician and social worker cannot be away for many weeks. We also use this blended learning for international trainees. We had teams from Pakistan, India, and Indonesia who underwent this blended learning. Now, there is more than one source of funding in the setting up of these CPUs. We may even call it blended funding. It may be a combination of funds or grants from the Department of Health, local government, Child Protection Network Foundation, UN agencies like the UN Population Fund, or international NGOs such as Plan International. There is always the question of how sustainable are the CPUs once they are set up. This is at the top of our minds even before establishing one. That's why one of the conditions for setting up is a local legislation for a budget for the CPU. Then the Department of Health Administrative Order also states that funding for the CPUs can come from the Gender and Development Fund of the government, and it also stipulates that the Philippine Health Insurance will develop a package for abused women and children. This way, it will earn some revenue for the hospital. Following the training and the establishment of the CPUs, all CPUs are encouraged to become members of the Child Protection Network. So that's why it's called a CPU network. And all of them do become members. And CPN provides several services for their member CPUs. We provide peer review, 24/7 consultation for difficult and complex cases, And some of the problems are not about the cases themselves, but may involve relationships between agencies. We have roundtable discussions for hot topics, common problems, or a need for a consensus for a protocol, etc. There's an annual national conference where updates are done. You meet everyone, and we also involve other stakeholders such as business. The statistics are centralized, and we offer the Child Protection Management Information System database for free. This database was developed in 2000 to facilitate case management and research. It can generate reports, statistics, track common patients and perpetrators, and it has different modules for physicians, social workers, police, legal, and mental health. Now, with regards to monitoring and evaluation, this is still really a work in progress. The administrative order of the Department of Health, already has the framework for it, but it still needs to be operationalized. So I'd like now to go to an example of Level 3 CPU, which is the PGH Child Protection Unit, PGH meaning the Philippine General Hospital. And as you can see from this slide, aside from the forensic objectives of the CPU, the child protection outcomes that the PGH CPU wants to attain are the treatment of medical and mental health problems, safety, keeping the child in school, connecting the family to community resources, and decreasing the secondary traumatization that may be brought about by the system. The PGH CPU team is composed of 6 physicians, part-time physicians actually, 6 full-time social workers, 2 full-time police, 2 part-time psychiatrists, 1 full-time nurse, and 1 part-time lawyer. The PGH CPU sees around 1,200 new cases a year, 80% of which are child sexual abuse cases. Now, from this article of Jones and colleagues, we know that there are many benefits to having a multidisciplinary team in the investigation of child abuse cases. For example, they found that it eliminates the need for multiple duplicative interviews. Fewer interviews may also improve the quality of the child's testimony. There is improved interagency communication. Well, in our case, everyone is under one roof. There's a team approach to decision-making that leads to more effective and efficient decisions, and professional satisfaction is higher. And this has really been the experience of PGH CPU. In certain cases where there is an increased probability that the child will not testify in court, which happens frequently in cases of child trafficking, a videotape multidisciplinary interview is done. And depending on the child's age, the forensic interviewer may be a pediatrician or a police officer. Younger children are usually interviewed by the pediatrician. The other members of the team, as you can see in this slide, listen at the other side of the one-way mirror, and they can put in their questions too. The child protection physician performs, all these different functions as illustrated in this slide. She performs a complete medical evaluation, also do forensic evidence collection, also diagnose and treat any sexually transmitted infections or other medical conditions that may be present, such as a urinary tract infection or intestinal parasitism, for example, and will provide expert testimony in court. The physicians also serve as trainers for the program, and as well as medical residents and fellows in pediatrics. The mental health services at PGH CPU are provided by child psychiatrists, and they do these different therapies. But the social workers now also do group work with selected teenagers. And next year, we will start a new project where social workers, among others, will be trained on trauma-focused cognitive behavior therapy. A memorandum with the Philippine National Police enabled the PGH-CPU to have 2 police officers on site. And so on-site filing of cases can be done, and the police attend the preliminary investigation hearings by prosecutors. They perform crime scene investigations, and they submit police report for board claims for victims' assistance, extra funds for them. They are also the trainers for the police who undergo the child protection specialist training. The legal services is provided by the CPU lawyer, such as legal counseling, preparation of legal documents, for complex cases may represent the child in preliminary investigation hearings. They also help in the Kids in Court program that prepares children that are scheduled to testify in court. 15% of our child sexual abuse cases reach court. The lawyer also handles law interns who may do electives at CPU. The social worker, which is really the glue of the whole team, handles both the acute and the long-term care. They serve as case manager especially for long-term case management. They provide crisis counseling, safety assessment, and family assessment. They do home visitation, and they also do the parenting skills training. Now, once everyone has done their evaluation, they come together for the case conference. The case conference has many objectives. It could deal with the filing of cases. It could also deal with cases where the child is unable to testify, or maybe a child is not safe, so protective custody needs to be done. It might be for something so specific as a suicidal patient with no caregiver and now needs to be confined in the hospital. Could be for long-term planning and care for children who are placed in shelters, and also for closing cases. For children from very poor families where survival day-to-day needs can barely be met, if at all, the PGH CPU social worker is involved in the long-term care. And this may mean additional services that are not routine, such as educational assistance, livelihood assistance, education of the community, either in monitoring or working with the CPUs or in prevention. And some of the patients, especially in child trafficking cases, may need a new community. So there's really, a wide range of services that are provided by the social workers. So I will end here and I may answer some of your questions. Thank you.
Thank you so much, Bernadette. This is Amy Vess again, the coordinator for the Global Social Service Workforce Alliance. That presentation was so helpful to get a good picture of the program in the Philippines, where it really is, it's great to hear about how formalized it is through the MOUs with the government, and the way that these CPUs bring together the multiple disciplines, such as the nurses and doctors and police and social workers, to be really institutionalized into a hospital setting, or so that it officially becomes part of the care system for women and children who've experienced violence and abuse. If anyone has questions, feel free to type them into the chat window. Bernadette did mention a lot about how the training is recognized by universities. I liked your example of how the funding is blended even, and the way that the CPUs also become part of local legislation, so not only at the national level but also at the local level. Jim McCaffery does have one question. If you can Oh, I see that you've already answered it, but he asks how long the program has been in place. And I wonder if you can just talk a little bit, too, about how this initially got started and how those discussions initially happened so that the MOUs could be signed with the government to bring in the university systems to recognize the training. If you can just tell a little bit more of the story of how this all got off the ground and when.
Well, once upon a time, there was only one CPU, and we knew that we could not serve the whole country. There were just too many cases. So we felt that the solution is to have CPUs across the country so that access for abused children and their families, will be easier. In fact, our goal is that they could access within 2 hours, depending on the geographic area, because we are islands. And so that's when we started, we approached the Department of Health for a partnership, as well as the Philippine National Police. Now, when we involve local government, we do a lot of lobbying. So we would approach the governor of the province and give a proposal with regards to the setting up of a woman and child protection unit in the provincial hospital. With the new administrative order from the Department of Health, it has been easier, and especially if you could provide, the framework where the funds will come from, what is the role of everybody, making it easier for them to say yes, then so far no one has said no, actually.
All right, great, thanks. We have a lot of questions coming in. A few about whether you provide services for children or do you include youth as well, and then also just another few facts about a question from Jim McMahon about how many CPUs are there across the country and are they all hospital-based?
Yes. With regards to hospital-based, majority are hospital-based. Although we do have some that are community-based, probably around 10 are community-based. And yes, we provide services to anyone below 18. But if it's a woman and child protection unit, then that means that includes adult women. Did I answer all that?
Yes, thank you. And one other question, and when we will open this up for discussion in just a moment, but and eventually it would be great to hear Lynette's take on this too. But one question that I'll address to you for now, Bernadette, from Nathan Linsk. He says, these are great presentations. I'm wondering if there are issues that have come up across the various disciplines in terms of their varied roles or challenges in collaboration.
Oh yes, definitely. There are many problems. Well, in the beginning, more so than now, because now we're getting better with the protocols. But even just understanding each other's roles took quite some time, and the limitations. Actually, for example, expectation is that when a child comes to the unit and she says who the perpetrator is, the expectation is that the police will immediately go and arrest the perpetrator. But it doesn't happen that way because, there are legal limits of who you can arrest immediately and, and the building up of a case. And then with regards to the physicians, for example, people get disappointed if the medical certificate says that there's no injury because they think that going to a physician will confirm whether there was sexual abuse or not, but findings are only in at the most 5% of cases. So again, the limits of the medical examinations. And when we talk about protective custody, because of safety issues, who will do it? The legal mandate is with a government social worker, but they also expect that an NGO social worker has the same powers, say, as a government social worker when they're not equivalent in terms of powers. So there's this, all of these things can really blow up, the relationship of a team if, the training did not take care of that from the very beginning.
Great. Can you say a little bit more about how that is moderated or facilitated, some of those challenges, or how the role of the network that brings together these different CPUs might help the CPUs in addressing some of those challenges?
First, I think that the protocols help, so that the protocol, for example, right now we have a new case management protocol in the management of child abuse cases. And it starts with reporting until the end, until it reaches court, and then after court, so it goes to all the different steps, what are the procedures that need to be followed, who does what, so that it's clear in black and white. The timeliness of it is written down. Now, in the training, we also have a multidisciplinary faculty. So we have trainers from different agencies who participate. And we have, and this case protocol that I'm talking about, for example, all the secretaries, we call Secretary of Justice, Secretary of Social Welfare and Development, Secretary of Local Government, the head of the National Bureau of Investigation, the head of the Philippine National Police, all of them sign onto this protocol so that everyone knows that this is what needs to be followed. So that makes it a lot easier. And during the training, we have sample cases, and the sample cases contains all of these problems that we have experienced already, so that ahead of time they know that you can expect this and this is how you're supposed to handle it. So, but of course, that doesn't ensure anything, because there are personality problems. So we may need to come in some of those, and do a case-to-case negotiation. But I think the preventive aspect is really written protocols that is, participated in by everyone in the making of it, and then signed off by all the bosses, the boss, at the highest position possible.
Great, thank you. We'll have one more question, and then we'll move on to the general discussion, where if people have questions for either presenter, we can do that. But first, a question from Jamie Costigan. She says, thanks for this presentation. Can you speak a bit about how children and families are involved in the case conferencing and decision making? And she's also interested in learning more about the parenting training in terms of the content and whether it's mandated.
Yeah. In terms of the case conference, first there's a case conference where it's just first only all the professionals involved. And then there's a case conference where you have the parents and the children involved, so that they can say what they would like. In fact, sometimes it's not just the parents, it may include the grandparents, who are the powers in the family. And there's a different one also wherein it's the child who also states what he or she would like to see happen. So in the end, in terms of what finally is decided on is contributed on by both professionals, family, and children. So they are involved in the decision making. And with regards what was I'm now forgot the second question to that. Can you repeat that?
Sure. It was,
the parenting.
Yes, the parenting training and the content and whether it's mandated.
Yeah, the parenting, that's where I think we need to improve. We have parenting modules. We have basic and advanced. And we also have parenting for parents whose children are the one with the sexual behavioral problems. Now, these are not mandated, so it's voluntary participation, but with the children, but with the parents, whose children are the ones who are, quote unquote, the alleged offenders, although it is voluntary, there is always in a sense, a threat that if they don't participate, then the police or maybe the courts will now be involved, depending on the child's age, of course. The age of criminal liability in the Philippines is 15, but in the new amended law, for serious criminal offense, and sexual offense is considered serious, then the age of criminal responsibility is 12. That means the court can become involved.
Okay. Thank you so much, Bernadette, for your presentation and for answering all of these questions. We will move on just to see if anyone has any comments for either speaker, or we'd love to hear about some of your efforts to form or work in multidisciplinary teams in the programs and countries that you work on, and just to talk in general about what some of your successes and challenges have been. We could also just start off this discussion with a follow-up from Nathan's question to see if Lisa or Lynette would like to add anything to his question in terms of the challenges that come up when, or issues that come up across the various disciplines in terms of their varied roles or challenges in collaboration. Lisa did have a few comments, but just to give either Lisa or Lynette a few moments in case you would like to add anything to that question.
Hello, it's Lynette. I don't think it's an issue of disciplines as such in terms of challenges in collaboration. What we have found is that, as Lisa says, it doesn't automatically happen. There does need to be some kind of a spark to make it happen. And I think more than disciplines is personalities and inclinations.
All right, great, thanks. And also a question from Jim McMahon. He's wondering how long and how intensively the CPUs stay involved with the children of the cases that are brought to their attention. Bernadette, that is directed to you.
Yeah. For the PGH CPU, which has more personnel and is a big CPU, we are involved for as long as it takes. So I have a patient that I saw when she was 6 years old, and now she's second year college, and she's still with us because it's a complex incest case. So there's really no time limit in terms of how long we are involved. A case is closed if the risk has gone down, and all the services have already been completed, including therapy. But it can always be reopened anytime that a new problem comes up. So the range of our involvement can be very, very short if really it's a stable family, really needing so few services, versus a really, really dysfunctional family where we can be involved for years and years.
All right, thanks. There's a lot of chatting going on about evaluating these types of programs, and I think in particular evaluating how the collaboration leads to stronger services, as well as better outcomes for the children and youth in the programs. Lisa, you're noting a number of types of data that you're starting to collect. I don't know if you have anything to add to that, either Lisa or Lynette or Bernadette. You also mentioned the beginning of the M&E process in the Philippines. I don't know if either of you have anything to add to that.
Right now, for example, for the PGH CPU, we keep track of re-abuse rates because that's one of our outcomes that we measure. And second, we also, one of our outcomes that we want is really for the child to stay in school, so as long as possible. And sometimes that means that we do have to give educational assistance. Third, we initially really wanted to track the follow-up rates for mental health services, and but we are dealing with a lot of difficulties there because in the Philippines, for example, there's a stigma for going to a psychiatrist because people will say that I'm not crazy. So if the child is not really suicidal or showing signs of really deep depression, then the follow-up would not be good, you know. So maybe after 3 visits, then they won't follow up anymore. So even if the services are free, I mean, all of these services that I have discussed are free. So, but of course, if they live very far, then there's the issue of how much transportation will cost. So there are so many other different factors that are involved in terms of follow-up care. So our social workers are mainly the case managers if the case is in the city of Manila and the nearby cities. But if they come from far-off provinces, then we have to endorse the case to the local government social worker. That's why we really want that every province will have its own child protection unit. That makes it easier.
All right. I would like to give Lynette or Lisa a chance to speak, and we will see if we can activate Lisa's microphone. Or Lynette, if you'd like to say a few words about some of the data as well as the conference, the upcoming conference in Nairobi, and how some of this information will be presented there.
And I think I have unmuted Lisa's microphone if she wants to give that a shot too.
All right, go ahead, Lisa. All right, if maybe her microphone isn't working, Lynette, would you like to address that in terms of the upcoming conference and then also in terms of the data collection and how that will be presented at the conference?
Yes, REPSSI is having the second REPSSI is having our second regional PSS forum, the 29th to the 31st of October. The theme is PSS and child protection. And there are sessions there about the certificate program. So we will post the data and we will happily send it to the Global Alliance to send around.
Wonderful. Thank you so much. And a related question that came in from Rita Muyambo about are the training materials open source? And this is to both presenters, if you can comment on what access people may have to the training curriculum that you use.
Right now, because we can only accommodate 15 teams in a year, the limitation to access is really because we're fully booked in terms of the training. That's why we are trying to also develop training centers other than the PGH CPU to be able to accommodate other trainees because of, you know, we don't want to have a bottleneck. So we hope that in the coming year we'll have at least one other training center, and that maybe by the end of 2015 we'll have 3 training centers.
Thank you. And Lynette, would you like to also address that question?
The question is about the materials. The materials are copywritten to REPSSI and UNICEF. We have shared them with a number of people who have needed them for a variety of reasons. And they have been cited in other works.
Excellent. I want to say thank you to both of you very much. We are nearing the close of the session, so I do want to hand over at this point to Jim McCaffery to provide some closing remarks before we close out the session. So over to you, Jim.
Thank you. Thank you, Amy, and thanks everybody. Those were great presentations and really good questions. And good questions and a good kind of discussion in the chat window around the questions. I guess I would just make 3 or 4 quick closing remarks. One is, of course, just to take us back to the big picture on this and on multidisciplinary teams in general, is that the purpose is to provide a better, higher quality, more accessible services to vulnerable children and families, and that multidisciplinary teams contribute to that. And I think we've seen some examples by taking a more holistic and comprehensive approach with more options for care, more awareness among individuals in the care environment about other choices they have for referrals and for help and for professional support and better decisions. And I think there is a less duplication, as we could see. I think the example from the Philippines around kind of one person doing interviews and collecting data for a range of the disciplines. I think the comprehensive approach, a good example was around, well, there's several, but one that caught my eye was the teacher who might have missed signs of abuse or chosen not to act, now is more likely to act and identifies, with the help of the training and the mentor support, a place to refer somebody, a child, to. It goes to the family support trust for that kind of examination and counseling, and then from, if the parents resist, again to the child-friendly unit. Yes. So, I just think those are really good concrete examples about how multidisciplinary teams make a very positive impact. And I think just a bit in terms of the other 2 items that came up in the questions. One, it doesn't automatically happen. And there are issues probably both of personality involved as well maybe as disciplines, because I think different disciplines bring a particular approach to problems and problem solving, which when combined maybe with personalities can have an impact. I think that Bernadette mentioned that for her, she thought the multidisciplinary faculty helped in the training process, and I think the idea, we did not bring this up here, but in our conversations beforehand, Bernadette had a really good example of a memorandum of understanding to start the process and to get agreement at the state level or when the unit was set up. And it included clear role expectations and role definitions and spelled out expectations. And I think for longer-term sustainable multidisciplinary teams, having very clear roles and expectations is very important. It doesn't guarantee there's still not going to be kind of internal issues on the team based on somebody seeing something or based on personalities, but at least it can help in this process. So those are my closing remarks. Very important subject. And let me go to the next one. If there are, first I wanted to thank Chris, Lynette, Bernadette, Amy, and to everybody that wrote in, and to especially to Lisa, who is Lynette's colleague in Zimbabwe. Great help. Next, if there are other events or opportunities that you would like to announce, you can do so in the chat room right now as we're doing these last announcements. Secondly, if you're interested in joining the Alliance and receiving notices about future webinars, please visit the socialworkforce.org to register. We're always looking for more members, because the membership, the more we have, the richer the discussions and the richer the input, the greater the opportunity for this kind of networking. And then there's a summary and recording of this webinar, as well as each of the past 11 webinars available on socialworkforce.org. I would encourage you to use these. Actually, they're very user-friendly, and you can skip through parts that you might not want to go to, and you can go directly to what you're after. So, so I think that's it. One note about the next webinar. This webinar was part of a two-part series. The next one is going to be called Multi-Sectoral Coordination at the Policy and Planning level. It's taking a level up from the community and looking at what policy and planning interventions support multidisciplinary teams, and look at how multi-sectoral or multidisciplinary collaboration has led to policy changes and a stronger social service system and better service for delivery for vulnerable families. And the speakers in that one will focus on experiences of planning across ministries and stakeholder groups to coordinate workforce deployment and service provision, and ultimately improving the effectiveness of care. We will be holding this in mid-November, and will soon email a more specific date. So I think that is it for now. Amy, anything else you want to add? I see you just said thank you for everybody. And Bernadette has invited everyone to a National Child Abuse Conference in Manila on December 2nd and 3rd. I'm just looking to see if there's any other announcements. I don't see any at the moment. Okay, great. So I think this is it, and we appreciate everybody's participation. And there is an announcement about the REPSSI Forum in Nairobi, the 29th through the 31st of October. Okay, that's it for now. Thanks, everyone. Look forward to the next webinar.
Thanks, too. Bye-bye. Night.